This prenatal and infant care webinar. This is actually our 8th educational session this year for the Prenatal and Infant Care Network for all the good healthcare and prenatal and infant care providers, in the Northeast Indiana area. And I think it's almost like we've saved some of the best for the last. And so I really want to tell you we've got a great information today that I'm excited to hear. And I think you all will probably feel the same way. That's why you're on the call. And I think we'll feel more so at the end of it. Laura, I'm going to turn it over to you, Laura Dwyer, who is the Community Programs Manager for the St. Joe Community Health Foundation, to explain who we have presenting and to introduce them.
Oh, okay. And then are we going back to introductions, Mike?
Yes. Oh,
okay.
You know what? Thank you. Let's do the introduction. Sorry. I apologize. Thank you for that prompt. What we really wanted everybody to very quickly do on this call, and what we want everybody to know who's on the call and who's in the network through here. So I think what might be as easy as I will kind of say your names, and hopefully it stays in pretty much the same order on my screen. If it bounces around, I'll be sure to have you jump in at the end and tell me if we've missed anyone. But we think it's helpful for everybody to know who's doing what work very briefly in the community. Again, I'm Meg Dissler with the St. Joe Community Health Foundation. And along with our team here, we do help coordinate the Prenatal and Infant Care Network. We have now over 400 participants on it, over 90 different organizations. And our goal is just to do whatever we can to support and strengthen agencies out there providing these services. Alice Hopfer, do you mind introducing yourself?
Hi, I'm Alice Kupfer. I'm a board member of the St. Joe Community Health Foundation, and I'm also on the Grants Committee.
Sorry, Elisa Shaw.
Hi, my name is Alicia Shaw. I'm a case manager with Healthier Moms and Babies.
Angie Phillips.
Hi, I am Angie Phillips. I am the program manager for the ECHO and Gear Up for Safety program at Lutheran Social Services.
Bree Beck.
Hi, I'm Bree. I'm with the Healthy Families program through SCAN. I am a family assessment worker or resource specialist with Healthy Families. So I just bring in the new families for our program. Thank you.
Thanks. Chelsea Harris.
Hi guys, I am Chelsea Harris. I'm the Health and Wellness Coordinator at Healthier Moms and Babies, and I will be speaking with you all here shortly.
Great. Danielle.
Hi, I'm Danielle Furge. I am one of the nurses at Healthier Moms and Babies.
Erin.
Hi, I'm Erin Harold, and I am a nurse with Healthier Moms and Babies.
Esther. E, are you out there?
She's muted.
Oh, sorry. Hi, my name is Esther. I am I'm one of the case managers from Healthier Moms and Babies. Thank you.
Glennis.
I'm brand new. I'm the mental health director with Healthier Moms and Babies.
Wonderful. Greg.
Gregory Smith Causey. I'm the fatherhood program coordinator at Healthier Moms and Babies.
Okay, let's see. Jackie.
Hi, everyone. Jackie Martinez, programs manager with Healthier Moms and Babies.
Kelly.
I'm Kelly Bauman. I'm with Associated Churches, and one of our programs is A Baby's Closet, and I'm the volunteer coordinator and development director.
Jay Elmer. or Jelmer?
Hi, it's Janet Elmer and Stephanie Good with DuPont Hospital, both childbirth educators and birth navigators here at DuPont.
Thank you, Janet. I did not figure that out with your email start. Let's see. Maria. We have two Marias. Maria Martinez.
Yeah, this is me. Hi, everybody. My name is Maria Martinez, and I'm a case manager with Healthier Moms and Babies.
And Maria Charlotte?
Yeah, I'm a nurse with Healthier Moms and Babies.
Okay. It has shifted around for me, so I'm not sure who I've missed. Please introduce yourself if I have missed you.
Hello, my name is Myla Rogers with Early Childhood Alliance, and I am the project coordinator for the project Engaging Child Cares to Impact Infant Mortality.
And I'm Pat Turner. I'm the Tobacco Education Coordinator with Tobacco Free Allen County.
My name is Corey McKenzie, and I'm the Bereavement Coordinator at Parkview Health.
I'm Taya Nakamba. I'm the WIC Director for Neighborhood Health.
My name is Madison, and I'm the Development and Administrative Coordinator for Healthier Moms and Babies.
My name is Tiffany. I am a case manager at Healthier Moms and Babies.
My name is Talia, and I'm a case manager with Healthier Moms and Babies.
This is Rochelle Bontrager, also a case manager with Healthier Moms and Babies.
I'm Mindy Hartwig. I'm the Development Director with Healthier Moms and Babies.
I'm Sarah LeBlanc. I'm an assistant professor of health communication at Purdue University, Fort Wayne, focusing on maternal health communication.
I'm Roger Reese.
I'm Mary Luter. Oh. Hi, Roger.
I knew that would happen. Roger Reese with Associated Churches. And we help folks. All you have to do is mention babies and we'll help you.
And I'm Mary Luterman, nurse supervisor for Healthier Moms and Babies.
I think we've got everybody, and I apologize for not being able to read all your names. I still keep trying to learn this new technology. But thank you for taking a moment to introduce yourself so you all know some of the other wonderful talent we have in this room to help moms. So Laura, how about I turn it over to you now?
Okay, so it's just so exciting for me to see all your faces. Wow, it's been a long time, as this whole year has. Today is all about interconception and preconception health. And we have amazing speakers today, and I'm so excited about it because we know if the mother's healthy going into pregnancy and healthy during her pregnancies, we have a lot higher percentage of a better outcome. And we need to take care of our mothers. Again, everyone should be raised in a safe, stable, nurturing environment. So I feel blessed in our community that we have a program of our own called Own Your Journey. And Chelsea Harris is here to tell us about it. She's from Healthier Moms and Babies, and she's going to tell us just how she is taking care of our young mothers and what the program is all about. So Chelsea?
Yes, thanks, Laura. Can you guys see my screen okay, my PowerPoint?
Yes.
Awesome. Thank you for the introduction. And again, thank you guys all for hopping on the webinar today. I am very excited to take the next 10 to 15 minutes or so and just share with you more about one of our newer programs here at Healthier Moms and Babies called Own Your Journey. When we developed this program, we specifically aimed to focus on that health and well-being of women before they become pregnant, as well as in between pregnancies. So you may hear that referred to a lot as preconception health or preconception wellness. So the goal ultimately with all of us on this call is to reduce the infant and maternal mortality rate here in Allen County. And like Laura said, one of the ways that we can do that is to help women become healthy and well before deciding to have a baby. Again, if we do that, decreasing infant maternal mortality rates, and it can also help decrease preterm births, low birth weight, as well as birth defects and things like that. So with Own Your Journey, this is a 9-week health and wellness program that was developed in partnership with the YMCA and Macmillan Health. And the target audience for this is low-income women. Typically, these women have some sort of risk or they are at risk, or they currently have some sort of health condition that could affect their pregnancy, such as high blood pressure, obesity, diabetes, and things like that. So that is typically our target audience. Age range, we get that question a lot. Childbearing years, so any women who really just wants to have a healthier pregnancy or live a healthier lifestyle. And we don't want to exclude the women who maybe already have kiddos and don't want to have kids in the future, because they also can aim and have a goal to get healthy for themselves, but also for the kids they currently care for. So keep that in mind as well. So with this program, we meet once a week, and it takes place at the YMCA. We meet for an hour and a half each week, and we focus on various different health topics that really just encompass your overall health and well-being. Some of the topics that we talk about are healthy eating and weight. We also talk about meal planning, physical fitness, mental health. We talk about family and life planning, as well as sexually transmitted infections and substance use. One of the big things that we do with these ladies the very first session is we establish goals with them. We teach them how to make SMART goals, so goals that are specific, measurable, achievable, relevant, and time-bound. And those goals we keep on the forefront of their mind throughout our 9 weeks together. And then even after the 9 weeks is up, we work with these women for an entire year, really just to be their motivator, their personal cheerleader, to keep them encouraged towards meeting their goals, as well as providing them with any resources that are needed after that 9 weeks as well. While they establish their goals, we also have some goals that we work alongside these mothers with, or I guess I shouldn't say mothers, the participants. Not all of them do have kiddos, but some of the goals we have for them is that we want them to be able to obtain health insurance if they don't already have so. We also want them to establish a primary care physician and complete an annual wellness exam with that primary care physician. If they don't have these items, then we will assist them. We refer a lot out for health insurance to Brightpoint. And then if they need assistance with calling a primary care physician, we will assist them in calling, Parkview or Neighborhood Health Clinic or some of the various other health clinics that we have here in the Fort Wayne area. One of the key pieces that goes along with our session is our journaling. These women receive a journal at the onset of the program, and each week that we meet, at the very end of the session, we give them some time to reflect and journal on the topic that we discussed. And then they also have a take-home portion of their journal that really just goes into more detail on that topic that we discussed for that week. After the 9 weeks is up, they have a journaling topic once a week for a year. So that way that kind of keeps them encouraged and motivated to meet their goals as well. This program is incentive based. So while they participate, they have access to a YMCA membership and all of the perks that come along with that, which is great. They love it. The YMCA membership, it gives them access to the Child Watch during our sessions, as well as when they work out. And then they can utilize their classes. They can utilize the wellness coach, the aquatics area, everything that includes the membership. We also give out other incentives such as gas cards. We have our Own Your Journey swag, we call it. So we have like fun little water bottles, t-shirts, bags, things like that, that they're able to receive while they participate. And I do want to mention too, we try to remove as many barriers as possible to allow these women to participate in the program. So again, when they participate, the sessions do take place at the YMCA. We have a Tuesday afternoon session and we have a Wednesday evening session that they can choose from. So Child Watch is available for them. And then if they need assistance with transportation, we partner with CTN. So we're able to transport them to and from group sessions as well. How do we measure the success of our program so far? We have these participants complete pre-surveys and post-surveys, and we really just evaluate on those. And so far we've had 13 women who have graduated the program. So the statistics you see to the right of the PowerPoint are based off of those 13 women. Out of those 13, we were able to assist all 13 of them and make sure that they had health insurance. 12 of the 13 established a primary care physician, and then 10 of the 13 obtained that annual wellness exam. Of those, 3 that haven't gotten the wellness exam, I still am actively working with them and encouraging them to get that completed as well. So we're hoping that we can get those completed. But yeah, if you look at some of the statistics on the right, I won't go over all of them, but some that stick out that I like to point out are just the familiarity with birth control methods that improved by 72% from the beginning to the end of our program. There was a 21% increase in women reporting that they regularly exercise each week, which is great. And then there was a 22% increase in women who have stated that they have sat down and thought about a reproductive life plan. And when I speak of a reproductive life plan, with this, we usually sit down with the participants and we just talk to them about their future. Do they want to have kids? If they want to have kids, how many kids would they like to have? How old would they like to be when they have kids? If you're not wanting to have kids right now, what are you doing to make sure that you're safe? As well as, again, establishing those goals and things that they want to accomplish before maybe starting a family one day. And if you notice below, so those are some of our girls that participated and successfully completed the program in our August and September cohorts, and they were showing off their fun little t-shirts. And so right now we do have 3 groups currently running, again, one at the Central Y and one at the Renaissance Point Y. And then we have a virtual group going on right now with Girls Rock and East Allen University. And these are just a few pictures. I love to show off our girls and brag about them. They're absolutely amazing. And completing a 9-week program and following all requirements is not an easy thing for any of us. So it's just nice to brag about them and show, you know, how happy and accomplished that they feel. And I love that we're able to keep in contact with these women for a year, because we always get fun text messages, you know, such as I had a mom text me the other day, and one of her goals when she started with us was to get back into school. And so she texted me and said she got accepted back into school and starts in January. So it's just little things like that. And, you know, there are a lot of different topics that we discuss, and, you know, we don't expect them to change their entire lives just by participating in this program. But if they can take a little bit from each section and just make little changes over time, you know, hopefully that will lead to big rewards. So how can you refer to this program? There are a couple ways to refer. The easiest probably at this time during our current pandemic would be to refer on our website at healthiermomsandbabies.org/request services. If you type in healthiermomsandbabies.org, you can also just go to the little button in the top right corner that says request services and fill out a referral form. If you are more of a paper referral form person, let me know, and I can definitely email that to Laura and have her send that out as well. And those can be emailed or faxed to me. We also have some supplies. So if you're wanting to have something to physically give to these women that you meet with in the community, we have little postcards that look like this. Feel free to shoot me an email or give me a call, and I would be happy to deliver some of those to your organization as well. So other than that, I think we have just a couple minutes for questions. Does anybody have any questions?
You can ask them if you want directly, or put them in the chat box, please.
Yeah, definitely. All right. Perfect. Well,
Chelsea, I do have a question, because I think it's really important how you really cover healthy relationships and unhealthy relationships. So can you just talk a little bit about that, because that really does fit into our topic as well?
Yeah, definitely. So when we do an intake with each participant and we ask various questions, and we do have a portion that relates to their safety and well-being. So if when we have those discussions, and we have those discussions throughout all of our groups together. And if there is a concern, typically, I mean, all the girls are really great. I mean, it's a group setting, so we're all able to, you know, support each other and talk with each other. And then if extra time is needed, then we will sit down with these women over the phone or before or after group and have a safe conversation with them and provide them with any resources that they may need, such as the YWCA or things like that. So, and we do talk about healthy relationships throughout, because, you know, when girls get together, they're very open about, oh, well, you know, so-and-so does this or says this. So it's just an encouraging, comfortable environment for them to be able to share those things.
Okay, thank you. Any other questions? I'm not seeing any in the chat box. No? All right, thank you, Chelsea. That's great. It's so exciting to have a program in Fort Wayne that's helping, again, young women be healthy pre and post, shall we say. So with that, we'll go right into our next speaker. I am so excited to introduce Dr. Emily Scott. She is Assistant Professor of Clinical Pediatrics at IU School of Medicine. For Dr. Scott, I've been stalking her for over 6 months to come speak to us, because what she has to say is really important when it comes to interconception and preconception health. So she's going to share some research and models on how to use well child visits as an opportunity to provide interconception screening, counseling, and interventions for our mothers. Again, we want all of our infants in Allen County to celebrate their first birthday, and this is a great way to do it. So, Dr. Scott?
Thank you so much, Laura. I am gonna tell you guys that, like, when Laura and I set this up, I think it was actually like 8 months ago, and I didn't know I was going to be in clinic today, and I don't have an office in my clinic space, so I'm squatting in somebody's office who doesn't know I'm here. So if they walk in, it's about to get really awkward, okay? So just FYI, if somebody walks in, it's their office, not mine. I am so excited to talk to you guys. I loved your presentation, Chelsea. That was so exciting. And I'm going to share with you guys a little bit of a project I've been working on for the past few years. So I'm going to share my screen and then share my slides to incorporate interconception care in pediatric visits. And the reason that I am really excited about this model is I'm a general pediatrician, so I'm not a neonatologist, but I'm really passionate about the health of infants and moms. And I always felt like my hands were a little bit tied when I wanted to talk about infant mortality with people, because, you know, aside from talking about safe sleep and breastfeeding, there just didn't seem to be a lot of action I could take to impact the health of moms and babies. And when I found out about this interconception care model, I thought, well, that's something we actually can do in pediatrics. And so we tried it. We're on our second year of doing this down here in the Indy area with one clinic actually up in Gary, which I'll talk about in a little bit. And it's been a really great way to engage pediatricians in the infant mortality crisis here in Indianapolis, or in Indiana. So we're going to talk about how to engage pediatric providers in interconception care. And I think I'm going to go through some of these slides. I have a feeling, because I follow you guys on Instagram, Healthier Moms and Babies, I think a lot of this is going to be a review for your group, but we're going to go through it quickly anyway. I'm going to stay on time. Have you guys been able to see the 2019 infant mortality prelim data already from the state? Meg is shaking her head no. So I will share this. Can you guys see yourselves in my screen? Is this distracting? Okay, I don't really know how to fix that, but I'll move you guys over here. Okay, here we go. We usually have a couple monitors, which makes this easier, but not today. Okay, cool. Okay, so this is the 2019 infant mortality data from the Indiana Department of Health. It was just released at the end of September. It's preliminary data because, as you guys are, you know, probably well aware, the babies that were born at the end of 2019 have not turned a year old yet. So this is the first time Indiana has released preliminary data. As you can see, we have a great reason to celebrate. Our infant mortality rate dropped down to 6.5 per 1,000 live births, which was actually the lowest it's been, I think, since it's been recorded, and definitely the lowest it's been in the last decade. When we look at these causes of infant mortality, that broken down 2018 versus 2019, we did see a decrease in the proportion of births that affected births that were due to or deaths that were due to perinatal risks. About the same congenital anomalies, but we did see a spike up in the SUIDS deaths, which I think surprised a lot of us because, you know, SUIDS in theory are the most preventable cause of infant mortality. So we're going to talk a little bit about how we combine some safe sleep work into this interconception care model as well. This is the 2020 March of Dimes report card. So this actually just got released earlier this week. So if you guys haven't seen it yet, it is available on their website. Indiana is in the same spot that we were, I think last year we have a C- from the March of Dimes. So that means we can do better. And we're really, you know, kind of the lowest or in good company, actually better than Ohio and Illinois. So we're kind of, the whole Midwest is kind of in that like DC kind of area. When we look specifically at Indiana, this is again is based on projected 2019 data. This is looking at the percentage of preterm births. We were at 10.2, which is where we were in 2018. And we also don't do very well when we look in terms of our race and ethnicity disparities. So we know that we have the preterm birth weight among Black women is 44% higher than among any other women in our state. So we're not doing very well from a disparity perspective as well. And then this just breaks it down by counties and cities. So I wanted to share this with you guys because you guys are actually doing better than my area is Marion County, where I work, is a D-, and Allen County is a C+. So your preterm birth weight actually was improved since last year. So you guys have been doing awesome work in your community for sure. So I think, you know, Chelsea already talked a little bit about this. What is interconception care? So it is defined as the care of a woman in between pregnancies, from the birth of one child to the conception of the next. And we know that this can have a really tremendous impact on subsequent pregnancy and birth outcomes. It also is a challenging time because it is a time when women don't really receive a lot of preventive health care. In fact, you know, I even, you know, have colleagues and friends who really only get medical care during their pregnancies. They're otherwise healthy young women, and so they may not see the need to have a primary care doctor or to receive care in between their pregnancies. We also know that access to interconception care is actually impacted by racial disparities, and there was a nice paper that came out a few years ago discussing that. Interconception care, in addition to preconception care, has been an area of active interest. In 2006, the CDC actually developed a preconception care work group, and they identified 10 different preconception health indicators that they felt like would be worthwhile for states to track, because the thought was that if we could make an impact in some of these markers, we would be able to have an impact on the health of mom's pregnancy and her babies. And so these are things that, you know, honestly, Chelsea talked about a lot of these already. So current smoking and depression, diabetes, you know, hypertension. So that kind of those chronic health states before pregnancy, folic acid intake, heavy alcohol consumption, weight inactivity, and then the postpartum use of a most or moderately effective method of contraception, and then the number kind of unwanted pregnancies. So what you've seen is I've starred 5 of these areas, and that is because those are the areas that we cover in the implicit interconception care toolkit. So implicit is a model of care that was developed by the March of Dimes about a decade ago, and it stands for interventions to minimize preterm and low birth weight infants through continuous improvement techniques. It's a mouthful. But this program was actually developed within family medicine clinics. So that was its initial basis. It was in some family medicine clinics in the Mid-Atlantic region, with the idea that, you know, the family medicine doctors felt like they weren't getting their women back for care between pregnancies, but they were seeing the infants quite a bit. And so could they do a little bit of healthcare for mom during those infant visits and still, you know, help the moms out as well. Why is interconception care important? We know that almost half of pregnancies in the US are unintended, and that doesn't necessarily mean they're unwanted, but they may just be mistimed. Just like Chelsea said, it may be that a mom, envisions having 3 babies, but she might envision having them, 3 or 4 years apart, but then gets pregnant, 6 months after her last baby's been born. Only about a quarter of women report receiving preconception care. By the time a woman begins prenatal care, it is often too late to modify many of the risk factors associated with poor birth outcomes. And we also know that a lot of women change some of their health behaviors while they're pregnant. So they may stop smoking, they may discontinue using certain substances, but then after the baby is born, they may revert back to those behaviors. So, we see this actually not too uncommonly in our patient population, where a mom has really been motivated and stopped smoking during her pregnancy, but then we see him back at 3 or 4 months and she started smoking again. And so the danger is obviously if she's still smoking when she conceives the next time, that can have a tremendous impact on the health of her next baby and the health of her next pregnancy. The implicit model is really based on the idea that we can screen and support moms by providing targeted screenings and interventions that have strong evidence for improving future birth outcomes. The whole idea behind this, though, was that the screenings and interventions had to be brief, and they had to be performable within the context of a well-child visit. So it couldn't be a screening that was going to take a really long time for the provider to do, or an intervention that was going to be very time-consuming, because the understanding is that the focus of this visit is really on the child, but the child's health depends on the family's health, and the health of your future patients depends on the health of the mom. And so it was really worked on and worked around to screen for 4 things: smoking, maternal depression, family planning, and multivitamin use. All of those have been shown in the literature to impact low birth weight deliveries and preterm birth. And the idea was to screen moms at all of her children's well-child visits from the time they are born to the time they're 24 months old. Really capture them in that period of time. There's a lot of well-child visits during that time, and we know that the ideal interpregnancy interval is 18 months, so you're really screening the mom through that period of time when we think it would potentially be healthy for her to get pregnant again around 18 to 24 months. The idea behind this is it's going to enhance access to care, especially for women who may not otherwise seek care. And why is it important to shift the focus to pediatric visits? We know that when moms are pregnant, they are really great about making their prenatal visits for the most part. But once their baby's born, that whole focus of mom and the family often shifts from the care of the pregnant woman to the care of the infant. We also know that even if moms don't have their own primary care provider, most of them take their infants really regularly to their pediatric visits. In fact, 92% of visits are usually attended by the child's mother. And we also know that women say that they're willing to receive health advice from the child's doctor. In fact, they looked at this before they started this program and found that 93% of women were willing to receive some health advice from their kid's doctor. There's 8 well-child visits in the baby's first year of life. And so we know that primary care pediatric providers, whether that's family medicine or peds, interact with mothers much more frequently than their own primary care provider or OBGYN. And so the implicit framework, we took it here in Indiana and loved the idea of the interconception care, but really felt like because of the SUIDS issue that we have here in Indiana, we really wanted to focus on safe sleep as a screening and intervention as well. So we added a 5th dimension to the implicit framework, which was safe sleep. And so we our goal was to implement screening and intervention for tobacco use, maternal depression, birth spacing plans, and use of folic acid at well-child visits from birth to 24 months. And then screening for safe sleep position and environment in the home with interventions as needed from birth to 12 months. So kind of capturing that period of time when SUIDs are occurring. So what did this look like? So I think the challenge was that this model was done in family medicine, and family medicine doctors are just really comfortable talking to moms because they see adult patients, and pediatricians, we talk to moms and dads all the time, but we're not definitely not super comfortable providing healthcare to women or offering medical advice. So I think that was kind of the barrier we had to break through, and why we wanted to do this program, because we wanted to see if this was even feasible to do within pediatrics. Because our thought was, if it is, this would be a really like kind of low cost, easy intervention to spread that would potentially be getting moms more interconception care if they don't have access to the cool program that you guys are running up there in Allen County. So in 2019, actually January of 2019, we started a quality improvement learning collaborative with 2 pediatric clinics within Marion County. We focus on Marion County. We had grant funding from the March of Dimes before they closed here in Indiana, and Riley Children's Foundation. And we really wanted to focus on an area within Marion County that had were the kind of higher risk zip codes for infant mortality. We really sold the model to the providers and talked about the why, and then really based it a lot in QI basics as well. After that initial kickoff session, we actually held 8 monthly webinars with both clinics together, where we went through our data, looked at our run charts, talked about our current PDSA cycles, talked about successes we've had and barriers, and then reviewed some newer best practice recommendations that may have come out over the past couple of months. These are the clinics we worked in. One was a clinic associated with the Marion County Public Health Department, had a pediatrician staffing the clinic. She also had a family medicine doctor who was seeing peds patients every once in a while, and a nurse practitioner. They had a social worker on site, also actually had an OBGYN on site in the same clinic space. So that was kind of nice to be able to refer moms over if they needed access to contraception. And then our other clinic was a general peds subspecialty clinic that was the Riley NICU follow-up clinic. We had 2 pediatricians there, and then also a social worker embedded in clinic, which was very helpful. In each clinic, we identified an infant mortality champion. So that was somebody, either an RN or an MA, who led the change in clinic. So we really wanted somebody very front line to be the project leader within the clinic. And that person met with me and one of our QI coaches weekly, and we're responsible for developing PDSA cycles, communicating with the clinic team, and then collecting and entering data into the database so that we were able to track our progress. We were able, through some of our grant funding, to provide funding for them to do this work for about 4 hours a week, which was really helpful. And this is how we did. So this was our public health clinic. And so we let them kind of do whatever they wanted in terms of where they started. We just asked them to pick a low-hanging fruit, and we'll talk about that in a few minutes. And so you can see over the 9 months of the learning collaborative, they were actually able to intervene or to implement screening and interventions for all 5 domains and sustain that over the last few months of the project. So that was super exciting. They did awesome work. And then our general peds NICU follow-up clinic. This is just kind of what you see with QI. So they were actually doing some of the screening ahead of time. They were doing some of the screening and tobacco, safe sleep screening and tobacco screening. And so they kind of just went full force with those and just, were more intentional about doing it. But then we had a super long gap where they moved clinic spaces like to a different building, and then our infant mortality champion left, and then our provider champion left. And so we had about a 3 to 4 month stall period, which happens in QI. And then we were able to kind of go in and finish up the project with them. And they were had worked on a nice workflow, and we're working through that process nicely at the end of our intervention. What was a positive screen? So any screen that needed an intervention was something that we termed a positive screen. So either a family reporting that baby wasn't sleeping safely at bedtime or nap time, if mom was using cigarettes or vaping, if she wasn't taking a multivitamin with folic acid, if she reported that she didn't desire a pregnancy in the next year and was not using a reliable form of birth control, and then if she had a positive screen on the PHQ-9 or the Edinburgh. And so when we look at our cumulative data from both sites over all 9 months, what we saw is that we, had actually the lowest rates of moms using tobacco. And we were picking up, about 10 to 20% of moms with some perinatal depression. Sadly, about 16% of families were reporting they weren't always placing their baby to sleep safely. We had a lot of moms who weren't taking folic acid consistently. or who reported that they really didn't want to have another baby anytime soon, but weren't using a reliable form of contraception. What we were also able to see, and this again is cumulative over the whole project at both sites, was that pediatricians were actually able to provide interventions with a fairly good rate, I thought. They did better with things that we are kind of already used to screening for. So most pediatric clinics do some screening baseline for safe sleep and depression. And so we saw that 90% of the time they were able to provide an appropriate intervention if that screen was positive. They did not do as well, but still, we're intervening over 50% of the time, which was our initial goal for like folic acid, birth spacing, and tobacco use. So we felt like, overall for our first year doing this, it was a success. We had to think about what made it feasible in pediatrics. And so we did have to do some adaptations to make the toolkit work for us. Some of that was a phased introduction of screening domains, and I'll show you that in a second. We also expanded our eligible visits. And then we had to talk a lot about scripting because, like I said, this was kind of a foreign concept. Safe sleep and depression, not so much, but once we started having pediatricians try to talk to moms about birth spacing and folic acid, I thought people's heads were going to explode, to be honest with you. Nobody was super comfy with that topic. So I think the biggest key to our success with the screening was we really implemented a phased implementation approach. So we were very proud. We worked for literally like months on this great data collection form that we were going to use, and we handed it to the clinics, and they were so overwhelmed. So we really took a step back and decided that we weren't going to try to do everything all at once. You guys may have heard the phrase, "Don't try to boil the ocean." It's a very famous kind of phrase in QI work. And so the idea is if you want to raise the temperature of the ocean, you're not going to put a lighter under the ocean and just, wait and wait and wait. You're just going to if you take out a cup at a time of water and raise the temperature of that cup, over time, you're going to, kind of see more, feel like you're making more of a difference than if you just put the flame under the ocean. So we really focus with the clinics on what we call baby steps, and really encourage them to not implement any changes that they couldn't make in the next week. So instead of trying to kind of put in this whole like complicated process, we said, they came to us with those ideas. We're like, no, like if you can't make this change by next Tuesday in a small like incremental step, then, that's just it's going to be too much. These clinics were already busy. Their workflow, we didn't want to impact their workflow too much. So we really encouraged them to look for the low hanging fruit and to make small changes over time. And use, it's funny, Chelsea used this too. We used our SMART aim. So we talked about making our goals specific, measurable, attainable, realistic, and time bound, and really again focused on what was our goal for this next week versus trying to think too big picture all at once. We used our PDSA cycles to guide the steps. I'm running low on time, so I'm going to skip over this because I'm assuming you guys know about PDSA cycles, but I can send the slides out later. We also ended up expanding our eligible visits to problem-focused visits. So instead of using the traditional model of implicit, which was to only screen at well child visits within family medicine, we actually screened at all visits for babies from birth to 24 months. And that just really helped get this into the provider workflow and the nursing workflow so that they weren't having to think, okay, is this a weight check? Is this a 4-month visit? They just screened everybody. And then the parents just got really used to having the questions asked. The challenge, that we had is we had, in particular, our NICU follow-up clinic was very hesitant to ask the moms about their birth spacing plans and their use of contraception. And the more I reflected on that it made sense to me because a lot of these moms have had prior poor birth outcomes. The kids who see us in those clinics are preemies or our babies who've had a high-risk delivery, complications, and the clinic team was just really worried that this was going to come off as offensive to the moms if they had a poor birth outcome in the past. So we looked around. We were initially going to use one key question, and then went with the PATH framework, which was developed by Patty Kaysen. And it's actually very similar to what Chelsea uses in her program. So the first question is, do you think you might want to have more children at some point? When do you think that might be? And how important is it to prevent pregnancy until then? And so if a mom said to the provider, oh, I am, thinking about having a baby, again, getting pregnant again in the next 6 months, then we talked to her about preconception care and making sure she got in to see her doctor before she got pregnant again. But if she said, gosh, I want more babies, but like probably not for another 2 or 3 years, then we would talk to her about what form of birth control she was using, and whether that was something that was going to help her meet her goal. We also asked permission before we asked these questions to mom. And so we kind of implemented a phrase at the beginning of the birth spacing and folic acid questions saying we're interested in improving health outcomes for your family. We are asking questions about your plans to grow your family. Is it okay if we ask those questions today, or would you prefer we skip this section? And I think that made it just a lot more comfortable for our pediatricians to ask these questions when they felt like the moms could opt out. Interestingly enough, we didn't hear that very many moms opted out at all. So I think it just shows that more of the discomfort was maybe on the side of the provider than other people. And then the other thing that we found was just really important was just making sure that we had good resources in place. So we did not want to leave anybody hanging, especially since these weren't areas that our providers worked in very often. And so we just wanted to make sure that they both had the scripting for the counseling down, had resources to hand out, had good ways to connect back to the primary care provider, Mom's OB, or like resources like Postpartum Support International or the Quit Now Indiana line. And so we just really worked with the clinics to make sure that their referral pathway was feasible and was easy for them to do so that they got a positive screen. It didn't take more than a few minutes for them to get the mom set up and then the family back out the door if that was appropriate. So that was our 2019 cohort. At the beginning, end of 2019, we were approached again by March Dimes Indiana, and they were really happy with how things had gone and asked if we wanted to do it again for another year. Of course, then we said yes, and COVID hit. And so we have had to really kind of change our plans a little bit. But what we wanted to do in 2020, which is now 2020, 2021, is to see if we could expand implicit screening into other areas of pediatric medical care. The area I was really interested in working in was actually the NICU setting. And so could we screen moms for their interconception health in the NICU because we know those moms are going to be at higher risk for having a future low birth weight or preterm baby. We also were interested in what this could look like in a non-general peds area. So is this something that we could do in a peds subspecialty clinic? And so we wanted to do that. And then interestingly enough, we met a pediatric hematologist who came to our presentation at Labor of Love last year. And she stopped us and said, hey, I've got an outreach clinic up in Gary. I'm really, appalled at the infant mortality rates up in the Lake County area. Would you be interested in working with us up there? And so we have been working in their sickle cell clinic up in Gary for the past several months as well. This is just kind of bringing up also additional modifications we need to make. So how, questions like when do you screen when a baby's in the NICU? When is the appropriate time to talk about some of these issues with mom, and how often do you need to screen? The sickle cell clinic up in Gary actually has a home visiting program as well, where they have a nurse going out and visiting the families and providing education in the home. And then of course, how to do all this during COVID-19 when you're doing a lot of the screening virtually, and it's not as easy to access resources potentially. But things are honestly going well so far. So we started back up in September once we got the clearance from IU to go back and do research in clinics, and we'll see how long that lasts for. But so far things are going well. And this is just an example. Depression screening is what the NICU started with first, and they've been able to screen the vast majority of eligible moms that they had chosen, and are really picking up a lot of moms with perinatal depression, which they said they don't think they would have been identifying before they started this program, even though in theory the moms are being seen often, they're always in the NICU, but were not being screened regularly. So I think they were really excited by what an impact they feel like they're making already. So future directions, we really are interested in expanding this to more primary care clinics within Indiana. There's a couple family medicine clinics who are doing it now here in the Indianapolis area, expanding to pediatrics. Can we do something similar in internal medicine? Where in our other pediatric sites is it appropriate to expand to, NICUs, other inpatient settings, and obviously expanding to other sites where moms receive services. So if you guys know anybody up in your area who's interested or would be interested in this, let me know, because we're always looking for new partners and new places to go. Because as you guys are well aware, supporting maternal and infant health is up to all of us. So super important for all of us to be on board with that. This is a link to the March of Dimes toolkit. And honestly, if you just Google March of Dimes implicit, you will come to this page right here, and you'll be able to find the toolkit on there. You can download it for free and look through it. And I'm always happy for people to reach out with questions. Oh, thank you.
Wow, thank you, Dr. Scott. What amazing information. So anyone, if you have any questions, we have about 5 minutes for questions. I put one in the chat box because I was curious. You talked about selling the concept to the providers. How did you go about doing that? Because I'm sure that wasn't easy at first.
You know, I just talk about it all the time. And I think that tying it back to, like, I started with the message of infant mortality. And I think you really have to go big picture and explain the why, and then kind of draw the connections for people. And that really helped. I mean, I'll be honest, I was told no by several other clinics. So, I mean, it's not an easy sell for pediatrics, because I think that, and that there's actually good studies on this that I can send you guys as well, but there's that concern that, like, people don't want to feel like if you do this, you're shifting the focus from the baby to the mom, and that's not the intention of the visit. But you just have to reframe people's thinking that, like, the health of the baby is so dependent on the health of the mom, and also the health of the whole family, right? And so I think that, you know, trying to find whatever it is to switch people's mindset was really important. And then really selling them on the fact that this isn't hard to do. The screenings are not hard. The interventions are not hard. And that it wasn't going to take a lot of extra time, because that's what people are worried about. They don't want their workflow impacted. And, you know, they want to make sure they're getting to everything they need to get to in the visits.
And was your assessment incorporated into EMRs, or is this just a paper?
Oh, shoot. I wish it was. I don't know if the EMRs, I don't know if the EMRs up in Fort Wayne are easier to work on.
No, they're not. That's why I asked.
They are not up here either. So we did an auto text within Cerner that we could, like, people could just pop into their note and do check boxes. But we did most of it on paper. And to be honest, I think this is an area that needs work. There was a lot of concern in different clinics about documenting mom's information in baby's chart. That's something as somebody who did pediatric newborn care for so long, I'll never understand, because I don't understand why writing that mom has depression is any more stigmatizing than writing her chart that she's got syphilis, which we document all the time, you know, or her chlamydia or whatever. Like, to me, that doesn't make sense. That's just the mental health stigma. But that was a concern, and still is a concern with some clinics.
Okay, any questions? I don't see any in the chat box unless I'm not seeing them. Raise your hand if you have a question. Hopefully Mark can see you. But thank you, Emily and Chelsea, so much for that. So we just have a few announcements, shall we say. So I just want to say a couple things. As you know, the St. Joe Community Health Foundation bought seats to the March of Dimes Implicit Bias online training. We still have we have 5 to 6 seats open. So if you're interested in taking that training, go to our website and register for it. We'd love to have you, and I can send you the instructions on how to access that. The other thing is we will be sending out a survey probably next week, and hopefully you'll fill that out because we want topics for next week, and we want your, or next year, and we want your input on what our most pressing needs are. And with that, I'm going to turn it over to Meg because she has an announcement for us too.
I unmuted yet? Yes.
Yes, you're unmuted.
Thank you. Mark, if you can share that slide for us as well. As Dr. Scott talked about, we have been watching the increased rate of SUDS and SIDS in this community and the importance of sleep safe education. We're calling it Sleep Safely locally. And if last year in the winter, and we really kind of kicked off in January or February in the first quarter before COVID, a community-wide effort to all be doing a common Sleep Safely campaign. And it kind of got put on hold a little bit because of that little thing called COVID. And we have regathered all the key partners doing this, and it's open to anyone in the community. But we do want to have an Allen County-wide Sleep Safely campaign. And that basically the goals of it are that there's key learning points, education points that we want to make sure all parents and care providers have about how to help a baby sleep safely. We want all parents to understand that babies should sleep alone, that babies sleep safest on their backs, and that babies should have nothing else in their sleep area. And we want to make sure every baby has a crib or pack and play, a safe place to sleep. So all of the, really pretty much we reached out to those who've already identified that they are doing sleep safe education. And we've all agreed that we could be working together with kind of a common curriculum. And so we're folding that out to those partners. And Mark, do you have a slide that you can share with us on that poster? That's like a one-page flyer. If not, I can try. There it is coming. And maybe in a minute. There it is. So that's, oops, we had it a minute ago. But it's a one-page flyer, and we are working on it that we want to make it open to the community for volunteers who want to be trained to share the word, but then also to really be working with community partners. It's a little more detailed than that, but if you're interested in joining the effort, I believe Healthier Moms and Babies is already involved in many of the people on the call. But if you're not and want to join us in this community-wide effort, this is a brochure that we would like to be having everybody distribute. And in the center at the bottom in that white spot between Alone Back Crib and Sleep Safely Baby, we can put a logo like we've got Mila there with the Early Childhood Alliance, where you can pass it out just, but everybody kind of said this was a lot of the common factors we want to make sure every parent knows. Laura, anything that you could think of that I've not mentioned on this?
No, we're very excited about it because all our community partners that do safe sleep training now are on board. And so it does give us a community-wide message, which is really that flyer and how to keep our babies safe. So we're very excited to launch that early next year, January. The only other thing in the chat, Meg, was will they have access to presentations? And yes, we record these webinars, as you know, so you can listen or others can listen. And then we will also have the presentations and any other information like that flyer on our website. So I think that's it.
We're at that 1 hour mark and we're mindful of all of you. And Roger, we would love to have associated churches with a baby's closet involved. So we'll follow up with you. Great, thank you.
Thank you.
We hope you all have a great afternoon and a very blessed and happy Thanksgiving with just your immediate family members, whatever that is, according to the CDC. So thank you. Be safe, everybody.
Bye. Thank you, everybody.